Hi, everyone. My name is Matt Rivera. I'm a family physician and I work in rural Western New York. I work at a federally qualified health center at FQHC called the Chautauqua Center, or TCC, and we serve patients that are the most vulnerable. We've been partnering with the American Heart Association with the FQHC Lipoprotein A Discovery Project, doing lipoprotein A testing in patients who are from disadvantaged backgrounds. And the title of the talk today is FQHC's Discovering the Heart of Justice, Lipoprotein A, and Cardiovascular Health Equity. Health equity is a real passion of mine. I'm a family physician, and I practice full spectrum family medicine, including obstetrics. I've worked with medical students. I've also worked with the Erie County Medical Society and the Medical Society of the State of New York about health equity issues and advocating for our patients. Lipoprotein A, as you all know better than me. I'm a family doctor. I'm not a scientist. I'm not a cardiologist. But lipoprotein A is an independent cardiovascular risk factor. And the American Heart Association launched a 3-year program with the Lipoprotein A Discovery Project. And we have become a similar project focusing on community health centers and FQHCs. We at FQHCs and community health centers face a unique set of challenges with our patients who have a lot of social drivers of health that impede their care, that affect their daily lives, and can be quite disruptive to their overall health. Then why am I talking to you today? I'm not the cardiologist. I'm not the scientist. I'm here to talk with you about how we can work justice in our preventative care. And I'm here to talk about faces behind the numbers. That titan of the American labor union movement, Philip Randolph, said, "Justice is never given, it is exacted," meaning justice is demanded. It is snatched from the hands of the people who keep it from us, because justice is our right, and health justice and health equity are patients' right. So when we talk about lipoprotein A, when we talk about cardiovascular health equity, my patients, despite their disadvantaged backgrounds, deserve the same quality of treatment, deserve the same quality of testing, deserve the same breadth and depth of interventions available to them as any other patient does. And yours do too. Chautauqua County is in Western New York. It's one of the poorest counties in New York. Heart disease mortality in Chautauqua County is 10% greater than the rest of New York State. Premature deaths are twice as great in Chautauqua County among Hispanics and Black non-Hispanics. 1 in 6 of my patients lives in poverty. 1 in 4 children in our county live in poverty. And that is a dangerous state to live in because poverty is destructive to health. TCC, we're a federally qualified health center with a 13-year history. We have about 22,000 patients. And we see about 100,000 visits a year. And the Dunkirk site where I practice, we have about 4,000 of those patients. And we have 2 full-time family physicians, 1 full-time nurse practitioner, and 2 part-time family docs. My personal patient panel is made up of about 900 unique patients. And year to date, I've seen about 2,400 patients. Well, during 2025, I saw about 2,500 visits. 52% of my patients are Hispanic. 41% of my patients speak Spanish as a primary spoken language. 76%, 3/4 of my patients live at or below 200% of the federal poverty level, and 1/4 of my patients live at less than 100% of the federal poverty level. They have a mixture of public and private insurance. Most of my patients have public insurance plans through Medicare or Medicaid, but these, do not be fooled because they have Medicaid, are the working class families that keep our community running. We practice full spectrum family medicine in our clinic. We've had about 80 or 90 prenatal patients this year. We delivered 4 patients last week. We're very excited about our prenatal program, but our patients, 18.5% of them are qualified as moderate to high risk. 10% of our prenatal patients are teenagers. 40% do not start prenatal care until the second trimester. You can see the closures of hospitals here. Why is this important when talking about lipoprotein A and cardiovascular health justice? This is important because the impact of lipoprotein A and other biomarkers of cardiovascular health are understudied in women in general, but especially in pregnant women. We do not know the connection between lipoprotein A and hypertensive diseases of pregnancy like preeclampsia, but we do know that women who have preeclampsia tend to have higher levels of lipoprotein A, and that is currently a neglected and understudied risk factor for these patients. We have been trying to introduce more lipoprotein A testing in our maternity care program as just a way to see. But as you can see here, 1 in 5 of our pregnancies that we care for is to a mother who has moderate to high risk. And hypertensive disorders of pregnancy are one of the leading causes of maternal morbidity and mortality. And if lipoprotein A has anything to do with that, we need to study it and we need to be prepared to identify that early. My patients have huge chronic disease burdens. They tend to be on the younger side, but they have barriers stacked on top of poverty, stacked on top of language barriers, stacked on top of systemic racism. Half of my patients with hypertension are uncontrolled. And a quarter of my patients with diabetes are at an A1C greater than 9%. Why is that? Because they're non-compliant? No, because the system is stacked against them. And doing advanced testing like lipoprotein A and being able to risk stratify these patients helps us to identify these folks that are already facing huge chronic disease burdens, but my patients, at least, are young to middle life adults that are at the ages where their cardiometabolic risk matters the most. These are the folks that if they can turn this around, if we can reduce systemic barriers, if we can peel back some of the effects of the stacked deck and give them the information that they deserve with advanced lipid testing, lipoprotein A testing, and intensive lifestyle management, these are the folks who will get the most return on their preventative health investments. To give you an example of some of the disparities and some of the diversity of outcomes, these are 4 teenage boys that I take care of, and one of these patients is not like the other. All of them have huge future implications for their cardiometabolic risk. You have a 14-year-old with a BMI of 34, prediabetes, severe obstructive sleep apnea, hepatomegaly, transaminitis. He's given an appetite suppressor to lose weight. A 14-year-old who is waiting 9 months to see endocrinology, who is waiting 6 months to get an ambulatory blood pressure. A 17-year-old who has had a GLP-1 injectable denied twice when his BMI is 51. Why do those three have barriers when the 15-year-old, who is arguably the least sick and has the least cardiometabolic risk, has access to Wegovy, has access to a GLP-1, and has done really well with his weight loss, and he's to be congratulated. He's playing baseball now. He's doing wonderful. Why? Because he has private insurance. And the other three have Medicaid. There is no better example that I know of systemic violence than this. This slide here demonstrates systemic violence. I've tested lipoprotein A for most of these folks. I've tested it in a lot of my teenagers and young adults. We cannot have these children just because they're growing up in poverty and they're growing up on public health insurance plans, having the deck even more stacked against them, having even more barriers put between them and their long-term health. These 4 boys all have opportunities to make huge changes that will affect the rest of their lives, but only one of them has the means. So my patients, to reiterate, are people young enough to prevent cardiometabolic disease. That's why we're doing lipoprotein A testing, to give them an idea what their risk is. Because it is immoral if we have the ability to advise people about the dangers that their health faces, and we don't provide that advice. We have a moral obligation as clinicians to advise people of their risk, and we cannot do that if we are not providing the most evidence-based, up-to-date testing, regardless of the patient's income status, regardless of the patient's immigration status, their race, whatever other barriers are put up there. These patients can prevent cardiometabolic catastrophe, but they are heavily burdened with social obstacles. My patients in my practice in rural Western New York deserve, and your patients where you practice deserve, the same quality of cardiovascular risk stratification that is given at a boutique suburban cardiology clinic. All of them do. I did some interesting math. I'm not trying to show you here that lipoprotein A makes people poor. That would be absurd. What I am trying to show you here is that my folks, I split them up into quintiles, and I graphed the quintiles of lipoprotein A levels against the average percentage of the federal poverty line and the average household weekly income. Lipoprotein A doesn't make people poor, but the purpose of this illustration is to show that those patients of mine, which are in the highest quintiles of lipoprotein A, are the most impoverished. This is genetic disadvantage stacked on top of economic disadvantage. And I don't know about you, but my family cannot live on $373 a week. And I have a heart attack on top of it because I don't have proper cardiovascular care. Poverty is a disease, and it kills slowly, and it kills in a dehumanizing way. We know there are systemic inequities in cardiovascular risk assessment. These have been laid out in journals. I have seen studies preparing for this talk where there are tens of thousands of participants, such as a study that recently came out of the United Kingdom, where 97% of those tested were white Europeans. We are leaving out huge portions of the population in our research and in our testing. And we have defined cases in the literature where we know that marginalization stacks with genetic risk to compound disease burden. My patients are full evidence of that. So what did I want to do? I wanted to do what was done in the paper at the bottom, Reyes, Sofer et al. I wanted to integrate lipoprotein A testing into prevention for my marginalized patients by doing, for all of my patients, at least one lifetime Lp(a) measure for all adults, and I've done it for most of my adolescents as well. Because this universal screening is the only way that I know of right now to be able to move towards a more equitable implementation of Lp(a) testing and cardiovascular risk assessment. The way to eliminate these systemic inequities are to offer it to everyone, because we know that Black patients and Hispanic patients, even when they have high ASCVD, are less likely to be tested than white patients. And to correct that, we have to make testing universal. One of my heroes, Dr. Paul Farmer, says there is an enormous difference between seeing people as the victims of innate shortcomings and seeing them as victims of structural violence. Someone built that structure. Structures do not get built by themselves. In public health, we talk about the built environment and how it affects people. That built environment was built by somebody. Those structures and that built environment will have to be unbuilt in order to achieve health justice and health equity. And it is by ensuring wide-reaching and broad access to the latest care, regardless of a person's status, any qualifier, that we are able to begin to deconstruct and debuild. We've had some barriers with implementing this type of testing, colleague skepticism, other competing projects. Now we've hired a nutritionist, so I'm looking forward to working with that person about lipoprotein A testing. But this is an affordable test. It costs $14 based on our contract with our lab provider, and it's covered by New York State Medicaid. I don't know how it is where you practice, but this is a cheap test. But it has the ability to have a huge impact on how we risk stratify and how we manage cardiovascular disease. Thank you for listening, and please go and do justice in what you do.